Welcome to GEMcast, the Geriatric Emergency Medicine podcast, where we discuss important topics in the care of older patients in the emergency department. I'm your host, Christina Shenby. GEMcast is produced with the Geriatric ED Collaborative. You can find more episodes on any podcasting app, and you can find the show notes on the resources page of gedcollaborative.com. Welcome back to GEMcast. I am Christina Shenby, and I'm joined by an awesome speaker, podcaster, emergency physician who is going to talk about a brand new topic that, in reflecting, I could not believe we've never brought up on GEMcast before in our 10 or 11 years of doing podcasts. So I'm joined here by Jeff Comp. Jeff, welcome to GEMcast.
Thank you so much, Christina. I'm so excited to talk about this.
He is currently an assistant professor of emergency medicine at the University of Arizona and Creighton in Phoenix. And he has done a fellowship through the Wilderness Medicine Society in wilderness medicine. Now, before you are like, wait a second, we're talking about older adults. Are we going to talk about them like wandering in the wilderness? This is giving very Moses vibes. No, we're not going to talk about that. We're going to focus on heat injuries and heat vulnerability. And Jeff, this topic came to mind. I had the opportunity to go on vacation with my husband this June. We try to go away once a year for anniversary trip. And this year we went to England. And England, you think of as like overcast, never quite too hot, never too cold. It was hot, hot,
Yes.
hot, hot.
And places are getting hotter. It's
hotter.
interesting. And I'm so glad that you're bringing this up as a topic. And like my little environmental and wilderness high horse is wilderness medicine is all kinds of things, right? And you can absolutely see heat related illness, cold, frostbite. I mean, these are wilderness medicine conditions that people see in very urban settings. So I'm so excited that we're able to talk about this.
Yeah, and I felt like, man, I'm struggling here because, of course, they don't have air conditioning built into their buildings because it never,
Doesn't get that
spoiler
hot.
alert, used to be that hot. But something it's almost like the climate, the climate is changing.
What?
I know.
What?
And so I thought, wow, how is this impacting in our more urban or rural, but especially in our urban environments where maybe we don't have the infrastructure of air conditioning in all the buildings or just people needing to be outside more? How is this impacting the health of our older patients? So that's why I brought you on. I feel like we should back up first and think about what is it about being older that makes people more at risk, specifically to heat injury or overheating?
That's a really great question to start off with. It kind of boils down to how our body changes and how our body can get rid of some of the heat from an environmental, insult. So first off, there's just blunted thermoregulation. That's the first one. So there's this decline in sweat gland functions, even skin flow. I mean, we know that vasodilation, tachycardia, these are some things that our body does in general to try to get rid of and dump off some of the heat. If you have some reduced sweating, we're going to result in like less evaporative cooling. If we're impairing our vasodilation, we lose a lot of that convective and even our conductive heat loss. So as someone gets older, they aren't able to get rid of that heat as well as some of our younger people.
It's funny because as we were walking around in London, I was like, I could do with a little less sweating, but I guess that is a good thing too. It helps you get rid of the heat. And so if you can't sweat as well, or you can't physiologically adapt to the heat, then you keep the heat in. What other things might contribute to this?
Yeah. Yeah. Even some general things. So decreased thirst sensation. Sometimes, our older adults don't necessarily have that same kind of drive. And in general, a little bit of just, I don't want to say this word, but more like frailty and some reduced mobility. So if they're not really able to get out of some of these warmer environments, they're not able to get access to, like you talked about, air conditioning or a place that they can escape the heat because of different medical problems or just changes in mobility status, they aren't able to get themselves away from that continued heat. And there are also, in general, as patients get older, we have more comorbidities, and some of these medical problems can either worsen heat-related illness or emergencies, or frankly, they can cause more heat production or decrease the body's ability to get rid of some of that heat.
As we think about kind of the multi-complexity, the comorbidities that we accumulate as we age, what are some of the big ones that come to mind when you're specifically thinking about heat illness or who might then be at greater risk for heat exhaustion or heat stroke?
I think we can look at this from a system-based standpoint. So if we go through like cardiovascular disease, so I'm thinking about heart failure, CAD, AFib, this is going to impact the amount of cardiac output when we're stressed. So the vasculature might be a little bit stiff, less responsive. We talk about medications that could affect or blunt some of the cardiovascular physiologic adaptations. And if we actually layer that on top of other things like dehydration, oh man, this becomes unfortunately a bit of a spiral into badness. Other things I think about chronic kidney disease. So inability or impairment to handle like fluids and some of the electrolyte shifts that are going to happen with dehydration, as well as unfortunately some of the aggregate effects of continued heat as someone moves from a heat exhaustion to more of a heat stroke. And sometimes these patients have a little bit more of these electrolyte shifts or might be prone to more things like hyperkalemia, hyponatremia, AKIs. And oh man, if we have a patient that's on dialysis or renal failure, man, if they're missing sessions during these heat events, that can really start to add much more to some of these issues.
Yeah, dehydration sounds like this keeps coming up, not just in this setting, but in general. The number of times that patients come in a little bit just weak and dizzy or not feeling themselves. And what do we think first? We think UTI, but really dehydration should be up there with the things that we're thinking about, common things being common. I mean, rule out stroke, ACS, etc.
Sure.
But it's just an incredibly common syndrome of not being able to sense that they're thirsty. They're just not able to sense their body's volume level as well. Or maybe they're not as mobile, they can't get up and get water when they need it. But then now here we're adding on maybe they have some kidney disease or they have, dialysis or they're on medications like diuretics that will also make them more dehydrated and change their electrolyte balances. So those are some big ones.
Yeah, and the other challenge, I mean, we just talked about cardiovascular and renal, and we'll talk about some other ones, but man, if there are multiple comorbidities, if someone has issues like CKD as well as heart failure or other things, we really just can't add a lot of fluid if we're concerned for dehydration. We have to do a bit of a balancing act to make sure that we're appropriately resuscitating and we're not overloading a patient as we're
Mhm.
trying to address some of these issues that are caused by the heat itself.
Right. What are some of
So
the other comorbidities we're thinking about?
I mean, we're going to go right down through the system. So neurologic, I mean, people that have either had some sort of a neurologic emergency or previous survivors of stroke. So impaired mobility, general impaired autonomic regulation, things like Parkinson's, dementia. And this is some of it is the physiologic changes of some of these neurologic disorders, but some of it is just the behavioral changes. So, a patient with dementia may not really recognize that they're overheating, even as their core temperature continues to increase. And then the last one's kind of a catch-all. I mean, all we're going through all of our other medical problems, diabetes, right? So if we're having some sort of neuropathy, that can also blunt our sweating and thirst receptors. COPD, we're going to increase our work of breathing, and in general, obesity can increase metabolic heat production, maybe decrease the effectiveness of heat dissipation.
More comorbidities means less ability to compensate and physiologically adapt to a stressor. You mentioned also medications, and of course, polypharmacy is a big problem we've mentioned before on Gemcast, but what are some of the medications or polypharmacy specifically that will feed into heat adaptation?
It's going to be mostly because of all of the common culprits that we see for our patients as they get a little bit older. So things like diuretics. Oh man, we brought this up. This is going to be dehydration, electrolyte imbalances. I mean, if we're having volume depletion and dehydration, as well as some of these electrolyte changes, that's going to set up for a pretty dangerous scenario. So, I mean, we think about someone that's on like a loop diuretic in July, they might come in with weakness, confusion. Just like you said, this isn't necessarily the infection. Now, it could be, but this also could be because they're just profoundly volume depleted. So we have to make sure that we're keeping these kinds of conditions on our differential as we're evaluating our patients. Other things like anticholinergics, what we're thinking about here is And this one can be a bit of a double whammy. So, one, the medication itself, it can impair sweating due to some of the muscarinic blockade. Obviously, if there's a little bit of an overdose, we can have an anticholinergic toxidrome. But the other thing that's concerning is we can have a little bit of delirium, especially with some of our older patients with anticholinergics in general, which would compound that muscarinic effect.
So it sounds like our anticholinergics, which, I don't know any geriatrics people who love anticholinergics. I'm sure there is a
No.
time and place for them, but for the most part, we try to avoid them. And in heat illness or heat risk, it sounds like that's a double whammy with muscarinic blockade. So now you can't sweat, and then also, urinary retention, delirium, etc.
Yeah.
Any
I'm
other
thinking
big
about the
ones?
Absolutely. I mean, I think about a scenario in which you have someone that's, in the summer and they want to take like a Benadryl because their allergies are going crazy and they have all these other medical problems. I mean, this can be a seemingly simple and benign medication that could really cause some significant
Mm.
downstream effects in some of our patients.
Especially because it's over the counter. So you don't need a
Yep.
prescription for it. So people
Yep.
think it's safe, which, it used to be when you were 40, but now if you're 85, it might not be safe anymore.
Yeah. Other medications I think about, a really big one is beta blockers. This is blunting the tachycardic response. So we know that tachycardia, increased heart rate, is going to help us dump off some of the heat. And if you're taking a medication that's specific job is to decrease the heart rate, the body is not going to be able to get rid of as much of a heat, get that blood to the surface of the skin to allow for some of that evaporative and conductive cooling to happen. The other thing to think about is a patient on a beta blocker may not be as tachycardic when they come in with heat stroke. So tachycardia is one of the things that we normally see. So don't really be reassured for with a normal heart rate. Now, in general, the diagnosis of heat stroke is temperature greater than 39 degrees Celsius plus ultra mental status. Like that's it. So we really shouldn't be using things like heart rate or lack of sweating to diagnose heat stroke. It really needs to be just those two variables. So ultra mental status, elevated temperature from an environmental cause. Now, that's a big asterisk because, oh man, Christina, what's the differential diagnosis for elevated temperature and ultra mental status? 1,000 things.
Right.
So, one of my big goals of coming on here is just to remind people hey, as you're doing your regular workup, as you're going through your next steps and evaluation, including resuscitation, keep this on your differential diagnosis, especially and even if we're treating our older patients that may not have that same classic story that we think about.
And that's so important because, we see ultramental status and fever, we rightfully think sepsis,
Absolutely.
but during the warmer months, we need to be asking about, well, where were they? Were they outside gardening? Were they outside on their porch? Did they have air conditioning? This is one of the big questions I love to ask the paramedics because they're the only ones who actually saw the home. What was the home environment like? Were they in a, top floor apartment without air conditioning, or were they in a nice cool space? And then I'm thinking more sepsis.
Yeah. Well, and the other thing to also think about is what were some of the other causes and reasons for the person to not be able to get out of the sun? Unfortunately, I work in Phoenix, Arizona, and people can have strokes. People can have heart attacks. Did they have a medical emergency that acutely prevented them from getting shade, getting shelter from the heat? So our differential is incredibly high.
What other medications, if I see on their list, might make me concerned?
Psychotropic medications are another one. So this can generally alter thermoregulation. It can cause a little bit of some confusion. So our SSRIs, our SNRIs, even some of our antipsychotics. So this interferes at the hypothalamic level on how our body treats and responds to heat. And these medications might also prevent a patient from finding shelter from the heat in general.
One of the other things, so we've got, all right, there's comorbidities, there's lots of different medications, and then we've also mentioned obliquely some of these social and environmental determinants, or I would even add, political determinants of health.
Yeah.
The- a lot of political policies impact your access to care or, your social and living environment. What are some of the key things or pearls that we can glean from the environment or the social situation that could make them at higher risk of heat illness?
This is a really important topic to discuss. And honestly, it's not something in the physician community we think about all the time, but this is really important. I mean, you brought this up. Lack of air conditioning. When you're on your trip to Europe, some places just don't necessarily have a lot of AC because classically, They haven't really needed it. But as lack of AC or inability to afford utilities becomes a little bit more of a problem with anyone, but especially with our older adults, we see things like avoiding AC because of the cost, utilities being shut off because of heat waves. That's a big public health issue. The really sad thing is, and I see this unfortunately frequently during the summer, is people that say, "Hey, I couldn't afford to use the AC as much," or "Hey, the apartment complex I'm at, not really the best and it's been broken for a while." And those are really hard cases sometimes.
Oh man, that's got to be tough in Phoenix.
Yeah, it really is. Another big one is living alone. If no one is really sort of seeing that there's been a bit of a mental status change, no caregiver or family to see some of the early warning signs or early symptoms of heat stroke, confusion, some decreased intake, some lethargy, things can get really bad sort of fairly fast. Same thing with kind of social isolation. So sometimes these patients prevent with a really advanced case of heat stroke when someone does actually find them, or we're able to provide some assistance.
We don't have quite as much hot weather as you do in Phoenix here where I live in North Carolina, but we certainly do see heat injuries and sometimes it's people who are unhoused and so don't have stable housing to go to during the day and
Yeah.
then are outside or having to walk around and then come in with a heat injury. So we've had a lot of kind of bad news, a lot of things that can go wrong, a lot of things that do go wrong. What can we do in the ED to make sure that we're recognizing it? You mentioned some challenges of, their vital signs may not be as reliable if they're on a beta blocker. How can we make sure that we are not missing heat related illnesses in our older patients?
That's a really great question and is super important. Understanding and knowing the definition of heat stroke, we discussed that. That's going to be probably the biggest one. The other one to also think about is understanding and knowing the sort of spectrum of heat related illness, everything from heat cramps, heat stroke, heat exhaustion, which are some of the milder to moderate forms. Really keep that on your differential. An older patient that presents with syncope, man, we kind of have a fairly normal workup. So I would sort of like say as we're thinking about these patients, but take that next step and see what kind of environment they're going back out to. And that's something that I think about a lot, especially in Phoenix. If I've treated someone, they're not really at the heat stroke level, but it's 2 o'clock in July, and I'm going to discharge someone that came with a heat related illness. I really spend a lot of time talking with them about what kind of resources are available outside of my department. How can they get help in their community to hopefully make sure that they don't come back to me as a more advanced heat emergency? So our patients can have some non-specific presentations. So think about confusion, some delirium, maybe even falls, generalized weakness, syncope. Again, the differential for this is everything, right?
Yep.
But when we have these patients that come in, thinking about heat is going to be important. Family and neighbors might notice first. So thinking about, hey, the patient hasn't been answering their phone, they've been missing medications. Unfortunately, usually by that point, it might be a little bit more advanced. And then we already went through this a little bit. So the mimics, right? We're going to be working up sepsis. We're going to be working up concern for stroke. We're going to be working up concerns for ACS. Sometimes these patients might be missed as a heat stroke. And that will also happen. They'll come in and the temperature is elevated and a sepsis pathway will be initiated and the patient isn't appropriately cooled. And what we know about heat stroke is mortality is directly related to the Tmax as well as the amount of time that the patient's body
Mm,
has been exposed to the elevated heat. So, one of the cornerstones of heat stroke management is cooling the patient down.
mm,
So the danger of not really thinking about this or not addressing it is we're going to be increasing mortality.
mm.
Unfortunately, there's not a good number, but we find mortality ranges from both classic versus exertional heat stroke anywhere from like the low 20s to up to even 60%.
Wow.
So
That's
if
huge.
yeah, so if we're able to catch this and identify it, we can really save lives.
Okay, so I have two questions for you because now I'm very motivated. I don't want to miss this because the longer they stay hot, the worse their mortality is going to be. So, first question, you defined heat stroke. We've got altered mental status and an elevated core temp. And I know you can get, seizures, coma, you can start to get more multi-organ system dysfunction with that. What's the formal definition of heat exhaustion? Is my first question. And then second question is when we're thinking about a core temperature, are you doing a rectal temperature in these patients when you have concern? or, in triage, they're typically getting a forehead temperature or a sublingual temperature. What do you do then if you're concerned?
Two great questions. So, first off, heat exhaustion, we can have weakness, some nausea, some diaphoresis, a little bit of some confusion, but mentation is preserved. I think that's important.
Hmm.
As soon as like we know that there are some challenges with using GCS in a non-trauma setting, but that's kind of the language that's used. As soon as you start having significant decreases in GCS, my mind starts flipping towards this could be much more of a heat stroke. Now, again, in our older patients, we're giving a binary decision and diagnosis of heat stroke versus heat exhaustion, but the line can be blurred because it's hard to understand or identify, well, is this like altered mental status a baseline? Is this what they're always like? So I would really encourage asking family members, asking the patient, really having a good history and saying, hey, is this kind of normal or is this a new thing that's also related to the increased temperature?
This is such an important piece of getting that collateral information. I think about this, with our older patients who are maybe have some cognitive impairment, or maybe it's acute delirium, we don't know.
Yep.
Similarly to patients with cerebral palsy who might not be able to express themselves or might not be verbal, but the parents know them really well, and the parents can say, "Yep, this is not normal, there's something going on." It's harder for an older adult if they live alone or they don't have somebody who knows them well, but often the neighbor or friend or family member.
And Christina, you teed me up perfectly for your second question, which was how do you get a temperature? Usually, these patients don't always walk through the front door. In my ED, unfortunately, when patients are coming in with a significant heat related emergency, they're brought in by EMS with some significant obtundation or significant change in mental status. But that might not be the case for some of our older patients. So, yeah, and I'm going to be honest, my hospital is the same way. Someone's going to swipe the thermometer across the forehead or maybe like put in their ear or something, and it's going to be totally inaccurate. So, the most important thing is to use that collateral to say, hey, what was the environment like? So that's where talking to EMS is so important. Talking to the family, saying, hey, man, we walked into their apartment or their house and it was pretty warm in there when we started. And then, yes, I'm getting a core temp. I'm getting a rectal temperature. You could do a Foley sensing probe or what? I don't know why I can't say this.
Temp
You
Foley.
could do a temp sensing Foley. And unfortunately, for some of my patients, they get intubated. You can do esophageal probes for central temperature management as well.
So we need to figure out what happened, get some collateral from EMS, from family, from others, get a core temperature, and now we know high temp for long times equals bad equals high mortality. So what can we do to start to cool them?
Christina, this is one of my favorite things to talk about because I have a bit of a soapbox. So at our hospital and in Phoenix, and actually lots of different places in the country, we're really trying to move towards a cold water immersion protocol and process for heat stroke. To be a little bit crass, in our hospital, we place our patients in a body bag filled with ice water and we watch their temperature decrease. So rapid, aggressive cooling is the best option. Now, I know not every place has that. And one of the things that I really enjoy doing is talking to new hospitals that are saying, hey, I think this might be an interesting thing to start to try, but we don't have a lot of these cases. How do we do this? So if you work at a place where this really isn't reliable, cool them down as fast as you can. So in my mind, cold water immersion is going to be the number one. If you can do it, that's the best way. Next, if you have some sort of evaporative cooling, this is kind of the spray and fan, that will work as well. The problem with that is the cooling isn't as metered and it's definitely not as fast. You're going to want to put ice packs on the axilla, groin, neck. You want to give cold IV fluids. When you go head to head, cold IV fluids versus regular room temp IV fluids can decrease someone's temperature around 2 times faster, but it's not fast enough.
Hmm.
So you need to augment that with these other kinds of cooling modalities as well.
Okay, so yeah, if I don't have a full, immersion tank, the body bag seems like a good option. Is it waterproof or do they have to be in a tub in the body bag so that it doesn't leak?
This is a whole complex thing to sort of like go through. To be honest, we went through a bunch of different materials to see what was going to work best. And at the end of the day, body bags are liquid impermeable, they're fairly low cost, and they're disposable. So we kind of keep coming back to the same tried and true method, which is actually outlined in a case report out of Stanford multiple years ago.
I mean, this sounds like a great option because every hospital has body bags. Now, first, I think we just need to rebrand. Let's not call it a body bag. Let's
Yes,
call it an
yes.
insulated plastic cooling. sleeping bag. I don't know. What do you
Oh,
want to call it? It's
no,
like a
I
sleeping bag, basically.
this is actually a question that I get a lot because people will tell me, well, yeah, like I'm having a really hard time talking to hospital admin and saying I want to put people in body bags. Like they really have a hard time with
There's
it.
a block
So
there.
right, exactly. There's a bit of an uncomfort with the terminology. Yeah. So let's say cold water immersion device is what we're gonna. That's how we're gonna
Let's
do
call it
this.
that.
Yeah, let's
Yes.
call it that. In practice, the bag just goes directly on the bed. What we do is usually when a patient presents, we start them in our room, we unzip the bag, put it just directly on the bed. We put the patient in the bag and zip them up to about chest high, add water and ice. We are already using, so we've gotten core temperatures. We usually place a Foley for continuous temperature management. We put them on the monitor. We can start IVs. We continue resuscitation. Again, because we know that the amount of time that the patient sort of is exposed to the heat is a significant issue in mortality. We try to do all of the other resuscitation in concert with cooling the patient.
This is great because a lot of the times, in textbooks, you'll see, oh, you need to immerse the patient, and they have some sort of bathtub looking
Yeah,
thing, which we don't have. But
no,
if you can just take a plastic, insulated, waterproof bag, put it on the bed, put the patient in it, that's amazing.
yeah.
So, logistical questions here. You can still do if you have the patient on the monitor, do the EKG stickers fall off when they're in the water?
Actually, not really. What we found is that some of the stickiness doesn't really change as much. We can have a couple of leads. It's hard to do a full 12 lead, but you
Yeah,
can have a couple of
you can have
leads
them on the
and get some,
monitor.
yeah, exactly. Get them on the monitor. Same with our pulse ox. We switched to a bit of a sticky pulse ox rather than that little like alligator clamp. And the great thing about the bag is it zips up right at the front. So I can pull one arm out. I can get IV access. I can kind of tuck it back in. We use a lot of elastic bandages, a lot of clear plastic adhesive bandages to really secure the IVs down. But then we're able to continue with fluid resuscitation as well as medication administration if we do have to do a little bit more of an advanced resuscitation. One of the biggest challenges, honestly, was where are we going to get the ice? That was one of the biggest, like
Oh.
weirdly and paradoxically, that was because that silly little machine that gives you a tiny little styrofoam cup of like that crunchy ice is
Yeah,
not
you've got
enough
a
to like,
Dixie cup of
yeah,
ice.
right.
You're gonna
It's
have to
not
get a
going to
lot of
work.
those.
Yeah, so we actually worked with food services, and early on in the process, our cafeteria was sending us up these big buckets of ice. And it was great because when we were starting the implementation, actually, this all started because of a resident driven QI project. One of my residents, amazing guy, Brian Feinstein, said, hey, we should just start doing this. And we went together and we talked to everyone from admin, nursing, even our techs, radiology, ICU. We're at the Arizona Burn Center as well. So we talked with our burn surgeons and said, hey, this is going to be what we're doing. What do you guys think? And I think because we had early buy in and champions from different levels, it became an effective process that we still continue.
That's fantastic. This is low cost. Everybody has the resources that they need to do it, and you can then quickly cool them. Now, if for some reason you can't get that or you don't have the ice, then sounds like options are the typical, spray them with cold water, put fans on them, put ice packs, use cold IV fluids. What about if it isn't helping or it's escalating and you're getting to the point of intubating and more aggressive cooling measures? What are some options there?
Unfortunately, they really aren't great. There are some commercially made cooling blankets that are kind of used, but those are usually for more of like a targeted temperature management in some of our post-arrest patients. There really aren't a lot of good options. It's continued evaporative. Again, if you're not able to do immersion, it's continued evaporation, it's continued cooled fluids, and making sure that you're doing everything you can to cool the room as much as possible.
Now, you mentioned cold fluids and also walking this balance of wanting to fluid resuscitate but not over resuscitate. What's a good amount of fluids to start with?
I mean, I think with anyone, you can always start low and add more if you need more. So, especially with some of our older adults, we touched on the fact that there might be some different comorbidities. If there's significant history of CHF with a decreased EF, I don't want to give them the 2 or 3 liters that they might be down right away. I'm going to rely on my ultrasound, frankly. I'm going to rely on chest x-ray and I'm going to see what my baseline start is. And if I can use my ultrasound to take a look at the heart, I can maybe evaluate the IVC and see if there's a little bit more room, then I can give multiple frequent smaller boluses, 500 or maybe a liter, and then progressively adding rather than just giving a lot of fluid and maybe a younger patient that
Right.
you might be able to assume can tolerate it.
Yeah, it's kind of similar to sepsis. You don't need to come in with 30 cc's per kg in the first half hour in these older patients. You can start with the fluid resuscitation, monitor their IVCs, monitor their vitals. Well, Jeff, this has been a great topic and some fantastic pearls that I've learned. So if I'm going to summarize what we've talked about, first of all, for many reasons, our older patients are at higher risk of heat exhaustion and heat stroke from their comorbidities, medications, things that could blunt their thirst response, or anticholinergics that make them less able to sweat. And our heat exhaustion, that is where we have maybe some mild confusion, but not real altered mental status. And then other symptoms like maybe some nausea, but some weakness, but normal mentation. And then heat stroke territory, we're getting into the truly altered mental status and elevated core temperature, which means we need to get a core temperature. So don't
Yes.
rely just on that
Yes.
sublingual or that forehead or ear thermometer. We need to get a true core temperature. And then height of temperature and how long they stay in the heat is going to correlate with your mortality. So we want to bring the temperature down pretty quickly. And the best way to do that is with cold water ice immersion. So put them into a zip up plastic bag on the bed, put some ice, put some water, keep your monitors, keep your IV going, give them some cold fluids, and keep the temperature monitor to make sure that they are cooling and not overcooling. What else?
Excellent. I think, Christina, I think the biggest things that I want people to be thinking about are one, recognition, and two, some just regular education and understanding. Patients that come in with some altered mental status, some confusion with elevated temperatures, we're going to say it again. It can be so many things. Just keep heat stroke on your differential. The presentation might be subtle, maybe a little bit of confusion, maybe a weakness, rather than like an obvious collapse. The other thing is trying to think about prevention and social support, understanding and recognizing that in some of our older patients, the best thing that we can do is make sure that they have the resources or the ability to get out of the heat to get some relief in some of those hotter days.
Absolutely. So maybe telling people, hey, you suffered heat exhaustion or heat stroke. In future, here's some ways to prevent it, or having somebody to check on you to see how you're doing, or trying to find cooler areas or even going, to the library or somewhere if you have transportation so that you have somewhere cool to go during those really hot days. Well, Jeff, thank you so much. It's been a pleasure talking with you and learning from you, and I appreciate you being here on Jebcast with us.
Thank you so much. It's been so much fun.
Thank you for listening to this episode of Gemcast. You can connect with me on Twitter with the handle @GemPodcast. You can also navigate over to gedcollaborative.com for more resources on the care of older patients.